So what I want you to do is I want you to look at what this looks like. So see this, see the soft tissue here? See how thin that is there? Okay. So basically what we're going to do is augment the soft tissue. So we go in there with the same thing. We're going to do everything the same because you can see how thin that is and it hurts them. So we numb it up, we're checking it, and then we're going to go in there and fix the soft tissue. So we do the same thing, except this time we're going to keep the papillas. Because I'm going to use the papilla as blood supply for my graft. And tomorrow when I show you grafting, I'm going to show you how we keep papillas. Okay? And we're going to lay a flap. So there's our flap. See the papillas I keep? Why? Because I want the blood supply to be there. Okay? So we're going to reflect this back. We're going to clean the implant the same way. Okay, we see all this stuff we're going to clean. You know, I'm going to kind of walk it. You know, you've already seen all this stuff. We go all the way through it. Okay. So there's a titanium brush. Okay. Now we're going to do something kind of cool after this. And so we're going to use acellular dermis, and you haven't seen this yet. So that's my acellular dermis. This is called periderm, okay, which is alloderm, periderm, just quite different. Okay. So I'm fitting it in place. I'm seeing how much I need, and I'm going to cut it. And now I'm going to use a radial firing tip to punch holes in it. Okay? And it's almost like a matrix. You go back and forth, creating a crisscross pattern. On one side, then you flip it around and you do the opposite side. Now, why would I punch holes in the acellular dermis? Well, it's never worked in my hands. But when you do that, this is Emdogain. We're going to put Emdogain on that. And we're going to go over this tomorrow a lot. Okay, we're going to show you some grafting. Here's my NDI creating a clot, and then I'm going to take my acellular dermis with my Emdogain and put it in there. Emdogain's a growth factor, and we talked about that. Okay. Then we're going to put it in there. Here's my, okay, with the fuzzy side towards the teeth, which is the dermis side. Okay. But we put holes on either side so the stem cells can get into it. Something nobody ever tells you, and I'll kind of tell you a little bit more about it in a minute. Then this is 6-O-polypropylene, 6-O-vicryl. 6-O-polypropylene would be used in eyelid surgery. That's how fine it is. Okay, and we use it because first of all it doesn't pinch and it's nylon. Okay, and because it's nylon, it makes it really nice to tie and it doesn't stretch. All the other braided sutures can stretch, so when I put my graft there, it won't move. We put it in place, and we suture it in place, so we go there. Now, after I suture it here, something you're going to see when I do grafts tomorrow, we suture it here. We also suture it here. It's called periosteal suturing. It's in the vestibule, and it contains the graft in this space, so the graft can't move. And if the patient pulls their lip up, they do anything, the blood supply is not disrupted. Right? And we'll show you tomorrow what I do with that. I have a couple cases like that. So now we've gone in here, we got the top sutures, and then what I do down here, you'll see in a minute, I will take my periosteal elevator, and I'm feeling the graft, I push the graft up, gets there, and then I'll put sutures into the periosteum that will stay there. These are vicryl sutures. They will dissolve in 6 to 8 weeks. Okay? And the reason for that, now my graft is locked in there. Graft stability, wound stability is really important. When you have wound stability, you'll have a nice result. And you're going to see the grafts that we do. I hardly ever take one from the palate anymore. I haven't taken a graft from the palate in years. Before, I used to use the laser before I punched holes in it. I didn't have good success. They were always from the palate. The problem from palatal grafts is it's too thin, it's too thick, it's too fatty, it's too irregular. This is always the same. Periderm is better than alloderm, much more predictable. Okay. So now my graft can't move. So it doesn't move no matter what I do. And I put, like 2, 3, whatever, how big the graft is, periosteal sutures. So in order to do this though, that has to be at the base, has to be at split thickness flap. Has to be.
Well, one more time?
Has to be a split thickness flap. In other words, you need to leave the periosteum on the bone down there. Because if you don't, you're not gonna suture the bone. Okay. So when you're done, that's what it looks like. See, my graft doesn't move. And then you seal it just like that. So this top sutures here stay for 4 weeks. We'll talk about that tomorrow because Pat Allen says they should stay for 4 to 8 weeks. We keep them for a minimum of 4 weeks. Okay? And the patient goes home just like that.